As Linda said, I'm Gail Taylor, and I'm the Director of the Office of Behavioral Health Wellness for DBHDS. We are the single state authority for substance abuse as well as mental health. We get federal funding at our agency that funds 40 community services boards across the state, okay? Virginia is quite unique in that our block grant covers our entire geographic area. In other states like Washington State, I'm really familiar with Washington State as well, they bid their money out, so certain segments of the state get money. We have a good system in that everyone has the opportunity to have resources to do mental health treatment, substance abuse treatment, as well as substance abuse or substance use disorder prevention, okay? So that just gives you a quick overview in terms of the context of where I work. What we're going to do now is talk about how in the state of Virginia prevention has evolved over the past 4 years. I've been there 4 years, realized in taking the job that Virginia was about 12 years behind the rest of the country. Washington State, for example, is the gold star as it relates to prevention practice and how they do their work. They have a lot of researchers in their state that have helped move their system forward. So what we have done over the past 4 years, and there's folks in the audience that are part of the CSB system, they know prevention has been on the fast track in terms of changing the paradigm and the way we do our work, okay? So what I'm going to do is talk a little bit about the history of what we did and what we do now. And then at the very end, I'm going to talk about our latest project, which we're really, really, really excited about, okay? This is our philosophy. Substance misuse, substance use disorders, and barriers to mental health wellness is a community issue that requires a community response. Historically, CSBs have been responsible for prevention services, and the way we did those prevention services was generally to partner with the school to offer classroom programs, okay? One of the things we realized, how fair is it of a kid who is in a classroom getting all this knowledge about the dangers of tobacco, alcohol, but then can walk down the street, there's people, offering drugs, they can go in and access alcohol. There may be a lot of trauma going on in that household. But they put it on a kid because of the knowledge gained for them not to use these substances. It requires a community response, which is why we changed the paradigm for the CSBs in that we are trying to move away from only programs. But the policy now is that a CSB has to partner with the local community coalition. And why is that? The coalition represents the community. You have voices of the community at the table, okay? Because it's not just the school's responsibility to address this issue, but it's also the key stakeholders in that community to come up with community solutions. So that's a huge policy shift and policy change for prevention services. Our mission is to prevent, and you can see this, one of the things that's really different with this one is that we're looking at strategies across the lifespan. Historically, DBHDS has only worked with 12 to 17-year-olds. Then we dropped the age to like zero to late adolescence. Now we look at across the lifespan, because when you look at our data is showing us that the biggest challenges or the biggest gaps in services are those services for 18 to 25-year-olds, and guess who? The elderly. As we look at the opioid epidemic, those two groups are having the biggest risk as well as deaths. We had a meeting last week with our state epidemiological outcomes work group, which are all the epidemiologists across our state agencies, and they said, y'all have to start looking at the older population. Because of pain, because of isolation, their deaths are escalating as a result of opioids. But our focus has been on the 30 to 55-year-olds. So we look at across the lifespan. And additionally, we have gone from just looking at individual programs, but doing community and environmental strategies. And what I'm going to do is to go over what some of those things look like. One of the drivers of all the work we do is the strategic prevention framework. Does anybody know what that is? Okay, we got a couple of people. If anybody gets any federal funding from SAMHSA, which is what we do, you have to use this model. This is an outcome performance-based planning model that prevention has to use. We have to start, and the reason we use it is because it's data-driven, and when your data changes, you have to change whatever it is you do, so it's very dynamic. We focus more of a public health model and look at population health as opposed to each individual making changes. We go on, once again, we look at across the lifespan, and we rely very heavily on a team approach via coalitions. We start off with the needs assessment. Historically, preventionists have thought, okay, the school wants us to do this, all right? For example, they want us to do this program, but now we have to ask the question, does your data support the need for that program? We have required all the CSBs in partnership with their community coalitions to do a needs assessment. So you go to what the data is telling you to do. We just did a needs assessment December 2017 when localities identified their priorities. So when they looked at the data, they realized that guess what? Not every community is being faced with the opioid crisis. We had 5 CSBs not identify opioids as the top issue. And truth be told, opioids is still not the top issue. Which substance is it? Alcohol, exactly. And all of our data is telling us that still. And then there's 5 CSBs and their coalitions that identified methamphetamines as the issue. Another one identified that their top priority is marijuana, okay? And opioids, as it relates to the data, did not show. So therefore, their strategies are going to be quite different as it relates to the work they're going to do. But unfortunately, we're still at a time when everybody needs resources. So oftentimes our data fits what resources are being made available. And there's a lot of money out there right now for opioids. Not saying that the opioid crisis isn't real, because it is, and we have to do things to address it to prevent death. Because with opioids, it's immediate death. With alcohol, it's a slower progression to death, but we cannot take our eyes off of what the data is telling us about alcohol, what the data is telling us about tobacco, okay, and all the other drugs. Once you have the data, you look at the capacity. Do you have the capacity to pull this off? Is your workforce trained? Do you have a coalition? Do you have partners? Planning, it's important to plan and have a logic model. Logic model being your data's here, linking it to your strategies and the outcomes you want to achieve. And this is like a quick version of what the SPIF is about. You implement your evidence-based programs, practices, and strategies, and then you evaluate. You make sure your evaluation plan is in the beginning. You evaluate for outcomes, because particularly in prevention services, we don't get a whole lot of money. The state of Virginia gives $0 for substance abuse prevention, okay, $0. So we rely solely on federal funds in order to address this issue. And you layer sustainability, making sure you have a plan to sustain not necessarily your program, practices, and strategies, but you want to make sure you sustain the outcomes. Because there's a lot of programs, practices, and strategies that are getting no outcomes. Folks are steady trying to sustain them, but why? You aren't getting any outcomes. So make sure you look at sustaining outcomes, as well as that everything that you do in this space, culturally competent, okay? So what it looks like at DBHCS, one of the things that we realized, because prevention had changed so much, we had to really train our workforce. The historical workforce was used to doing programs in the schools, or doing the program off the shelf kind of program, whether it's life skills or too good for drugs or too good for violence. They were so accustomed to doing those programs. Being that prevention has changed, we had to develop a new skill set. Those skill sets around needs assessment. Those skill sets around how to do an evaluation. The skill sets around how do you facilitate a meeting? How do you identify outcomes? So it's a whole different skill set. So we've spent a lot of effort and resources to make sure that we have a trained workforce. The CSBs have approximately 363 employees in terms of the prevention staff. This is one of our major efforts that has changed tremendously. Historically, when our agency looked at youth access to tobacco or youth using tobacco, they were spending $10,000 per CSB on doing programs, learning about the dangers of tobacco. SINAR's goal, the SINAR initiative, the goal of SINAR is to make sure that youth do not have access to retail tobacco. So what does life skills and knowing about the dangers of tobacco have to do with access to tobacco? Absolutely nothing, which is why we had to do a huge policy shift to do something different, because the importance of the SINAR initiative, every state and territory in the country has got to keep their retail violation rate under 20%, which means that if any young person goes to purchase tobacco at a retailer, that no more than 20% should be able to purchase. There are parts of Virginia where 33% of young people that went to purchase tobacco could purchase. There's one locality that 35% of youth could purchase tobacco. It's important that we stay under the 20% because remember that block grant that I was talking about that we manage? Virginia gets $44 million for prevention services and for treatment services. If we go over that 20%, guess what happens? The block grant can go away. The first penalty is that they'll take 40% of the block grant away, and that's for prevention and for treatment services. We were able to get the treatment folks' attention with this, especially the executive directors, when they heard that about the treatment money going away. So therefore, we had to work really hard to bring our RVR rate down because it was creeping up to like 14% in the state of Virginia. One of the reasons is that we don't have a really good tobacco retailer list because being a tobacco state, we don't have tobacco licenses in the state of Virginia. We have a partnership with the Alcohol Beverage Control Board. They help us to do youth inspections. We provided them with a list of the tobacco retailers. They have a team of youth that do underage buys, which determines the RVR rate, okay? Our retailers, our partner at ABC, they were upset because our list was so inaccurate that whenever they would do inspections, 4 out of 5, the retailer was either closed, it was a vacant lot, or it was a residential home. So we had to do this huge project with the CSBs where we had each CSB drive every street, every road, any CSB folks in here with their coalitions? Oh, they're back there so y'all can tell the story in order to identify every tobacco retailer. And as a result, they drove 56,000 plus miles, as you see up there. They identified 7,161 retailers, and they removed that amount of retailers from the list. So yeah, ABC had a problem with us because the list was so raggedy, bottom line. So you see all those dots up there? You see those are where all our retailers are. We have a project called Counter Tools that it goes straight into the database. This whole project has received national recognition. And so we're really excited about that because Virginia wants to be on the map like Washington State's on the map with all of the different things that they're doing. This is giving us national recognition because what happens, they identify the retailers and all these retailers get merchant education. All right, in terms of what the penalties are for selling to youth. As a result of this effort and identification, our RVR rate is dropping. It's now down to 10.4, yay rah. We want to get it down as low as Mississippi had gotten theirs down. Theirs is 3%, and we're somewhat competitive, so we hope to be able to get our RVR rate down even further. So that's an exciting project. One of the things that's really interesting with this is that the Virginia Department of Health, their medical directors are very interested in this project because you can almost overlay this data in terms of tobacco outlet density with health consequences. All right, these are the areas where we see disparities. We see that most of these retailers are linked to socioeconomic, low socioeconomic areas and more so to people of color. We have a Partnership for Success grant, which is it's like $9 million over 5 years in order to address prescription drugs and opioids. And one of the things that we have done, we use the SPIF model to identify the highest need areas, because one of the things in our office, we've decided not to issue any more grants, because once again, the beauty queen grant writers, they get the money. They may not necessarily have the need, and there's areas that don't have the capacity to write a good grant, but their need is great. So what we do, we look at the data. And what does the data say? What parts of the state need the most money because they have the greatest issue? So this is one of the first projects that we rolled out. We identified these 25 counties and 10 cities that had the greatest need. This data was originally collected in 2015. So at that time, they had the greatest need as it related to prescription drug overdoses and heroin deaths, all right? So we have been working on this project. And then while we were working on this project, the federal government issued all the opioid state targeted response money, which means that every state and territory got X amount of dollars in order to address the opioid epidemic. One of the things that worked well for us in our office is that we'd already identified the highest need communities, like you saw on this slide. These resources allowed us to expand our reach. So we were able to award 35 community services boards in partnership with their community coalitions more resources, because one of the things we realized, 2015 data is different than 2016 data, different than 2017 data. So there were opportunities for more communities to access this money. So we constantly, like we were saying with the SPIF model, is dynamic. You continue to look at your data in order to make different decisions. So we added many more on the prevention side, many more localities to receive prevention dollars. Things like, for example, they're building up their community coalition so that they have all the stakeholders at the table. Not just prevention folks, but they want the treatment community on the coalition. They want the recovery community on the coalition. Some communities have identified that they need to have veterinarians on their coalition because of all the diversion of opioids that are prescribed to pets are, not being used in the way that they're supposed to be used. So therefore, vets need to be a part of their coalitions. One of the things we just found out last week on our state epidemiological work groups, one of the greatest areas of abuse right now are on the other side of the road. When you're driving down 64, you're driving down 95, rest areas. There are more and more overdoses occurring in the rest stops. Okay, so that's important data to have as we look at possible strategies. We're looking at access issues, because with opioids, the greatest source of opioids is what? Family and friends, exactly. So give her an A+. So we're identifying strategies that are heightening the awareness of family and friends as it relates to sharing their drugs. There's probably very few people in here, and I'm not going to ask you to raise your hand, when someone's at your house and they have a headache and you'll say, oh, I've got some prescription that I used to have, because you didn't properly dispose of it, okay? Particularly if it's an opioid, one of the things we're working on is to make sure people have the disposal packs in order to properly dispose of their opioids. Another prevention strategy, one locality, they're working with the pediatricians, the orthopedic surgeons, and the oral surgeons, providing lock boxes in their offices to anyone that is prescribed an opioid, so that they could take that lock box home in order to prevent those drugs from getting into an unlikely hand, okay? Those are some of the things that our preventionists are doing, because once again, we're working to keep these drugs out of the environment and decrease the possibility of them being misused, okay? One area that we do get resources from the General Assembly is for mental health promotion as well as suicide prevention. We have been implementing mental health first aid. We have approximately 700 trainers in mental health first aid that go out free of charge to teach mental health first aid, to learn the signs and symptoms of mental illness and resources, so we're excited about that. We've trained approximately 40,000 community members. We're doing suicide prevention. These areas right here we have 5 regional suicide coalitions that look at the data to see what target populations they need to reach in order to planning and strategies. We provide a tremendous amount of resources for them to identify probably some of the strategies you heard about with the previous speaker. We provide these training in assist as well as zero suicide, and we also convene an interagency council at the state that are all the key stakeholders with suicide. Historically, we've had a family wellness initiative, and the family wellness initiative, we give out $1.25 million annually, and we've served 500 families, over 2,000 individuals, but that was over the course of 18 years. This is one of the main programs that we have had to retool and reinvent, because these programs are very, very expensive, and looking at the evaluation data, we were seeing improvements in behavior by 1%. A lot of the programs, we were seeing a decrease in behavior as it relates to focusing on the kids. So what we have done, we have completely changed what we're doing with this, and we are framing everything around the ACE study. Has everybody heard of the ACE? Who has heard of the ACE? Good. So y'all know all about ACEs. How we're looking at it as our paradigm in order to create ACE-prepared communities, as opposed to just having families in a program learning new skills when they have all those environmental factors that are going on. When we have kids that are exposed to trauma at an early age, but no intervention taking place until they're having problem behavior. So once again, our paradigm shift is really changing. ACE scores are high in the population, increased multiple health and social problems, and there's an intergenerational link to ACEs. So once again, when we start building community capacity to address ACEs early on, we hope to make an impact community-wide so that the community will be healthier as opposed to just, once again, people in a program. So, and I understand we're going to have questions when all of us finish, and so if you hold your questions, I'll be delighted to answer them. And I know this was quick, but thank you for paying attention. Take care.